Good afternoon. I'm Leonard Baines, Dean of the University of Houston Law Center. Welcome to Health Coverage at a Crossroads, Key Developments in Affordable Care Act and Medicaid Regulation, which is hosted jointly by the Health Law and Policy Institute of the University of Houston Law Center and the Tillman J. Fertitta Family College of Medicine. The law school is a top-tier law program with multiple programs in the top 50, and most notable for this conversation, our Health Law Policy Institute is ranked number 9 in the nation. So we're very glad to have this conversation on the Affordable Care Act. Is what the law school tries to do, the law center tries to do, is to bring important issues to our audience and to provide light but not heat on the issues. So the Affordable Care Act is informally known as Obamacare. It's a landmark US federal statute signed into law in 2010. Some have described it as one of the US healthcare system's most significant regulatory overhaul and expansion since the enactment of Medicare and Medicaid in 1965. Some of the key features are that insurance companies were required to accept all applicants without charging based on pre-existing conditions or demographic status, except age. The act initially mandated that individuals buy insurance or pay a monetary penalty, and the insurers cover a list of essential health benefits. Young people were allowed to stay on the parents' insurance plans until they were 26 years old. The act provided for the expansion of Medicaid state coverage, which requirement was made voluntary by the Supreme Court. The ACA has faced strong political opposition, calls for repeal, and many legal challenges. But for the most part, the act has survived. It also has been part of the most recent battle over the federal government shutdown. And there was some concern, or there is some concern, that healthcare subsidies will expire on December 31st, 2025, likely causing healthcare costs to the consumer to go up. Our experts are very knowledgeable about all these issues. They will discuss them in more detail. I will introduce each expert, and then after each of them speak individually, we'll all come back together for a roundtable discussion. So our first expert is Ken Yanda. He's a professor of practice of community accountable health in the Department of Health Systems and Population Health Sciences for the Tillman J. Fertitta Family College of Medicine. He teaches classes focused on improving health and healthcare of the underserved populations, value-based care, US healthcare financing, comparative health systems, and health policies. He has 40 years of experience, industry experience, and real-world experience, and he brings us into real-world experience to the classroom. He's held executive positions at several national insurance companies. In addition, he served on the executive committees of both state and national health insurance advocacy organizations, and currently serves on the executive committee of Every Texan, formerly the Center for Public Policy Priorities. He's a law school graduate, University of Houston Law School graduate. He's also certified by the National Association of Health Underwriters as Affordable Care Act professional. Let's welcome Professor Yanda.
Hi there. Good afternoon, everyone. Give me just a second to share my slides and we will get started. Okay, hopefully everyone can see my slides now. And thank you, Dean Baines, for the introduction and the opportunity to talk a little bit about a topic that I spend a lot of time talking to medical students, MBA students, and others about. I'm going to give a quick overview before we get to some of our other speakers today on the Affordable Care Act and what's going on in Medicaid these days. I always like to start with the Census Bureau, who tracks each year how much how many people have health insurance in the United States, and this is a chart that shows the 2024 levels of coverage, where you see that about 8% of the United States is uninsured, 92% has health insurance, about 2/3 have private insurance, and most of those have employment-based insurance. Um, and about 1/3 of the people have Medicare or Medicaid. You'll notice some trends in terms of increasing numbers of people with direct purchase ACA marketplace type products. Not much growth in the employment-based insurance, and actually a decrease in Medicaid in the last year. However, if you look at this over the last 15 years, you'll notice that there's been a significant change since the passage of the ACA in the reduction of number of uninsured people and the corresponding increase in insured people. About 26 million more people covered now than back in 2010. At the same time, there actually is a small decrease in the number of people with employment-based insurance, and a very large growth in number of people with individual insurance policies, primarily due to the Affordable Care Act. You'll also see a growth in Medicare, basically because we're aging as a population, and then also growth in Medicaid. I'm going to talk a little bit about each one of these sectors as I go forward here for a few minutes. As Dean Baines said, the big changes in the health insurance marketplace under the ACA. There was the expansion of Medicaid, originally the idea for all 50 states, but after the Supreme Court decision in 2013, it became optional, and not all states have expanded Medicaid. The idea of essential health benefits put into place, including the fact of preventive services with no copayments or deductibles, no pre-existing condition exclusions, restrictions on the ability to charge different rates for people based on their medical conditions, young people staying on their parents' plans, the elimination of annual and lifetime maximums in terms of benefits, and then some within the ACA individual marketplace, where people were getting tax credits. There was standardized cost sharing. You may all recall bronze, silver, gold plans to standardize cost sharing at the time of services, as well as for certain low-income folks, cost sharing reductions where they got a lower deductible, lower copayments if they purchased a silver plan. The result of all this was a significant increase in the number of people with insurance. Uninsured dropped. There was an individual mandate that was later, well, not technically repealed, but the tax penalty for not buying insurance was zeroed out. There continues to be individual marketplace subsidies, and now enhanced subsidies that we'll talk about in a couple minutes. And there was an employer mandate for employers that have more than 50 employees to offer insurance. There's been some minor changes in those along the way, but still intact. The result of all this has been a sort of a growing government and individual roles and a shrinking employer role. It's always confusing for people to figure out where people generally get insurance. And so I like to think about this as an XY axis with age along the X axis here from babies to old people, and on the Y axis, increasing income levels. And so if you think about it, people have Medicare if they're over age 65. If they're low income, below 133% of the federal poverty level, they have Medicaid. If they are low income and in nursing homes, they are likely to have both Medicaid and Medicare at the same time, dual eligibles, as we call them. There's a CHIP program that existed prior to the ACA that covers children in low-income families that make too much money for the Medicaid program. And then people, basically over $40,000 or so an annual salary probably have employer-sponsored insurance. However, if they don't have employer-sponsored insurance because they're working part-time jobs where they're not eligible, or they work for small employers that don't offer health insurance, or they're self-employed, they're eligible for premium subsidies if they buy an individual marketplace plan. And finally, this last section right here are the people who are both eligible for premium subsidy on their monthly premium amounts, but also available for these reductions in their cost sharing, lower deductibles, lower coinsurance that they have to pay if they're in this in this place right here. But as we have already mentioned, there's several states that did not expand Medicaid after the Supreme Court decision. So you'll notice Texas and Florida being the largest ones, but generally Southern plans. I always point out that Wisconsin did not expand under the Affordable Care Act, but they had a Badger Care in place before the ACA that covered people up to 100% of the federal poverty level. So they don't really count in my view. They've pretty much expanded. So that's what the map looks like. So in states like Texas, because we did not expand Medicaid under the ACA, we're still stuck with a program that looks like it did prior to 2014, where the STAR program, which is Medicaid Managed Care, covers lots of children and pregnant women, actually above the federal mandated level, and also disabled people and seniors that are in nursing homes. It does have a very small CHIP program. We do have a lot of people with private employer-sponsored insurance. We have the ACA marketplaces, but unfortunately in Texas and Florida and the other states that did not expand, we have this coverage gap, which are people who make too little money to be eligible for a federal subsidy, but because Texas hasn't expanded under the Affordable Care Act, we still have quite a number of people, probably 1 million to 1.2 million people in Texas that are too poor to get health insurance in Texas. There are quite a number of other uninsured people in Texas that are actually eligible for subsidies under the ACA, but do not take advantage of them. So here's what's been going on in Medicaid subsequently to the Affordable Care Act. The real big Medicaid grew from 2014 to 2020 because of the expansion states. But then in 2020, there was a really significant increase due to the pandemic, in which during the pandemic, the states were required to maintain enrollment without letting people drop off the rolls. But then starting in 2023, there was this unwinding, as we call it. And so we've now dropped down to about 72 million people covered under Medicaid. The percentage of people in states varies quite a bit in terms of Medicaid enrollment. So you'll see here that states like California, New Mexico, New York, Kentucky have quite a high percentage of their population that's in Medicaid. Other states, much lower in Texas, and a number of the states that did not expand Medicaid have among the lowest Medicaid enrollment as a percentage. This map on the left is the same one from the page before. What's very not surprising to me, but I like to point out to people, is if you look at the states where most of the uninsured people are, and this is a map on this side of adults that are uninsured under age 65, you'll notice that the states that did not expand Medicaid, Texas and Florida, tend to have the most uninsured adults. And Texas, far and away, is the statistical outlier in terms of having the most uninsured people, not just because we didn't expand Medicaid, but also because we have fewer unions in Texas, we have fewer small employers that offer health insurance, fewer large employers that offer health insurance in Texas than most other states. And we also have quite a number of immigrants who are not eligible for any programs. This is just to show you the decline that's going on in the employer-sponsored market. On the left is the rate of employers that offer health insurance to their employees, with, again, the small employers being the lowest percentage and trending down. But then in addition to that, also, for an employer that offers health insurance, fewer and fewer of their employees are actually taking employer-sponsored insurance, largely as costs have gone up in that market. So you do see a bit of a shift from employer subsidies for health insurance to instead in the federal subsidies under the federal ACA Act. This is an example then of what's going on with the ACA. We now have about 24 million people with Obamacare programs, Texas and Florida being the two biggest states Texas has about 4 million. Florida has 4.7 million, far and away the two largest states in terms of individual insurance coverage. And you'll see this really amazing growth chart that really started during the pandemic when the subsidies, or the advanced premium tax credits, more correctly they're called, these tax credits were enhanced during the pandemic and have continued through 2025. That's the big debate that's going on right now in Washington about whether or not they should extend these enhanced APTCs or go back to the original ones. We'll have some more discussion about that, I'm sure, later. The other thing that I just always like to point out to people, and I know that Dr. Reed will talk much more about this, is just to remind people that insurance does matter. Having health insurance actually improves health outcomes for people. And this is just a meta-analysis that was done at the beginning of this year in the annual review of public health that points out here's 10 different studies that all have said having insurance actually improves health. As you might imagine, after spending 30 years in the health insurance business, I believe health insurance is really important for all of us to have, and that's kind of supported by all the recent evidence. So to wrap things up, there's been a significant reduction in the uninsured through the ACA and the Medicaid expansion. Coverage saves lives. The ACA marketplace is picking up because as employers retreat or employees find out that they can actually get a better subsidy from the federal government than through their employer. And some employers are actually moving to defined contribution, where they simply give their employees a set amount of money and let them buy an individual product. Texas has grown the ACA enrollment tremendously. But now we face the OBBBA, which has created a number of different barriers to coverage, both for Medicaid and the ACA, in the name of reducing fraud, waste, and abuse. We'll have some more discussion about that in just a minute. The question that we all have now is how many Medicaid enrollees are going to lose coverage via the OBBBA. We have some estimates from the Congressional Budget Office. We still don't know if Congress is going to extend the APTCs. I'm not betting on it. The concern from insurance companies' standpoint is that if the first people who will not keep their coverage, if the enhanced APTCs go away, are going to be the most healthy people. That moves the risk pool to higher. And so you have insurance companies that have raised their rates what they needed for regular medical trend or in medical inflation, plus a factor for assuming that the risk pool would actually be deteriorating because of the loss of the enhanced APTCs. So those of us who hang out in this space really believe the uninsured rate is going to go up for the first time ever in the United States. It's a question of how bad it will be. And from the healthcare provider standpoint, be a doctor, a hospital, a pharmacy, not just bad for the enrollees, but the whole healthcare industry is going to be challenged by the loss of coverage. With that, I will turn it back to Dean Baines for some other introductory comments before we get to our roundtable.
Professor Yanda, before you go, for those in the audience who may not know what OBBA is, what is OBBA, and what does that stand for?
Oh, the One Big Beautiful Bill Act that was passed this summer, HR 1, some people know it as. This is the act that extended the 2017 tax rates that were in place, and as pay-fors for those tax rollbacks from 2017, they looked for Medicaid and ACA reduced federal payments for Medicaid and ACA as the pay-fors for part of that bill. I'm hoping that one of our next speakers will talk more about OBBBA.
Okay, well, thank you for the clarification for our audience sake. Thank you. Next up, I'd like to introduce Katie Keith. She's the founding director of the Center for Health Policy and the Law at the O'Neill Institute, where she oversees the center's work on demystifying the important role that litigation and courts play in health policy. As director, Keith advises policymakers and conducts research on a range of health policy legal issues with an emphasis on access to coverage, affordability, transparency, and equity. She is also a lead contributor of rapid response analysis for the health policy at a Crossroads series for Health Affairs Forefront and maintains a faculty appointment at Georgetown University's Center on Health Insurance Reforms. Her analysis is regularly featured in national and state media outlets across the country. From 2022 to 2025, Keith was on a public service leave from the O'Neill Institute to serve as Deputy Assistant to the President and Deputy Director of the first ever White House Gender Policy Council. As Deputy Director, Keith oversaw the Council's domestic policy portfolio. She previously served as an appointed consumer representative to the National Association of Insurance Commissioners. Prior to joining the O'Neill Institute, Keith advised nonprofit and foundation clients on ways to secure state and federal health care priorities. She received her JD from Georgetown Law School, Law Center, and holds a master's in public health from Johns Hopkins. Let's welcome Professor Keith.
Thank you so much, Dean Baines. And for better or worse, I will be talking quite a bit about OBBBA. So folks should prepare yourselves for that. So let me pull up my slides here and hopefully folks can see that. So thank you for the opportunity. I can't think of a more important time to be having this discussion. Building a bit more on what Professor Yonda just talked about, I don't think you can really understand what the changes that we are walking into in 2025, both from Congress and from the current administration, without sort of knowing where we've been. And so, you know, Professor Yonda talked about this a bit. I think it's very, very, very important to understand that we have just reached peak enrollment under the Affordable Care Act. So he mentioned that there are more than 24 million people with health insurance through the individual market, healthcare.gov, or, you know, some states, it's 21 states now, maybe 22 states run their own marketplaces, things like Covered California, DC HealthLink, a whole range of different options depending on where you live, but many people recognize healthcare.gov. And you can see over time how enrollment was relatively flat through these marketplaces and really did pick up, as Professor Yonda mentioned, during the pandemic, thanks in significant part to these enhanced premium tax credits, this enhanced financial help. So a steady increase, and we're now sitting at peak record high enrollment, even as we're about to talk about all the changes and potential disruption and headwinds that are coming for these markets this year. On the right-hand side there, you can see the variation by state. So Professor Yonda showed you the increased enrollment in Texas, which is also reflected here. But everything I'm going to talk about, keep in mind, as we talk about coverage losses and changes to the marketplace, are going to affect everywhere, but disproportionately impact those states with the highest enrollment. So we're talking about the states that are marked deep blue. So Texas, Louisiana, Georgia, West Virginia. And so keeping all of that in mind as we're walking through some of these changes. So first thing to know, peak enrollment for 2025. 2025 has also marked peak popularity of the Affordable Care Act. So Dean Baines in his opening remarks discussed some of the trials and tribulations that we've seen about Obamacare or the Affordable Care Act over the years. And you can see from this historical data in terms of polling when the law was passed in 2010, it was pretty deeply unpopular, maybe deeply is too strong, but under 50%. And over time, you can look at that red line there and see that there were many instances over time where the law was actually more unpopular than it was popular. That really shifted in 2017 when you saw Congress attempt to repeal and replace the Affordable Care Act. It was a huge animating fight for probably the first 7-8 months. It culminated with Senator John McCain in July of 2017 with a very dramatic thumbs down on the Senate floor. And ever since then, the law has been more popular than not. And as you can see, has reached sort of peak popularity this year, as we're sort of on the precipice of many of these major changes that are coming. Even so, I would point out the peak popularity is still no higher than, I don't know, 65%. So that's pretty good, but this is not sort of the law has never reached the levels of popularity of Medicare, for example. But again, you can see that much broadening the chasm between popularity and unpopularity. And Dean Baines, and actually both the dean and Professor Yanda mentioned some of the features, but you can actually poll the public on what do they like the most about the law. I won't cover all of these. Many have been mentioned already, and they're probably not surprising to you, but coverage for pre-existing conditions, allowing your child to stay, your dependent to stay on your health insurance plan until they turn 26, the ban on annual lifetime limits on care, and these subsidies that Professor Yanda mentioned for low and middle income Americans themselves. So 2025 so far is peak enrollment, peak popularity, and the law just survived its 9th Supreme Court challenge. So folks are probably familiar with what I would refer to as sort of the 3 legal existential challenges to the law that we've seen. The first was in 2012, where the court upheld the individual mandate, but made Medicaid expansion optional, as has already been mentioned. King versus Burwell, which was over the validity of, whether these subsidies that we've been talking about can only be available in some states, but not others. And then a huge challenge as recently as 2021 over the individual mandate once again. So far, the law has come through, I wouldn't say unscathed. Optional Medicaid expansion, especially in states like Texas and the other 9 states that have not yet expanded, has been significant, but you can see how many times the law has been up to the Supreme Court and is still very much standing strong. Earlier this year, the Supreme Court issued its 9th decision in a case called Braidwood versus Kennedy, Braidwood Management versus Kennedy, and the court there, very wonky challenge on the appointments clause, which I'd be happy to talk about if that's of interest, but upheld essentially the preventive services requirements under the Affordable Care Act, meaning, about 150 million people or so have continued access to covered preventive care at no cost sharing. And that, was pretty broadly available. So both the individual market as well as through job-based coverage. So lots of litigation. I think the Affordable Care Act is the most litigated piece of social legislation in history. So all of that sets the stage. Peak enrollment, peak popularity, unscathed generally through the courts over all this time in the law's 15-year history. And that really sets the stage for what we're seeing in 2025 and looking ahead. So I wanted to spend a little bit of time on the executive action that we've seen so far under the current administration, and then the congressional action and inaction that I think will have perhaps an even bigger impact, and that has already been mentioned here. So starting with executive action, the Trump administration in June of 2025 issued a quite sweeping rule to really reshape some of the rules and requirements around marketplace coverage. And when I say marketplace coverage, again, it's individual market coverage, affects the subsidies that people have, healthcare.gov, Covered California. That's the arena that we're talking about. I'm not going to go over everything. The rule was 501 pages long, so very technical, but had some really important and significant new changes that would have gone into effect very quickly. So a rule that was finalized at the end of June that would have changed coverage requirements for open enrollment beginning in November and coverage beginning on January 1, 2026. So many changes. Some of them, I've got a few examples on the right hand of the screen. New enrollment barriers. So for those who qualified for no premiums to, very low income people to enroll in coverage would have been charged a $5 premium penalty until they came back to the marketplace to renew their eligibility. The rules would have shortened the annual open enrollment period, making it harder and giving folks less time to enroll in the coverage they needed. There would have been new paperwork requirements, requiring, again, often low income people to try to verify their projected income over the next year, which can be a challenging task for many of us, but especially if you're a shift worker and working, more than one job, it can be very challenging to estimate your income and provide paperwork in advance. And then changes to the way that the premium tax credits, these subsidies are calculated, and the out-of-pocket costs that people might face. And some of those changes actually had implications for people with job-based coverage too. The rules, I don't have this on the slide, but I was thinking this would be important. The rules also gave states less flexibility. So those 22 states that run their own marketplaces would be less able to kind of set their own requirements. That was a big benefit of coming up with your own marketplace and not using healthcare.gov, as states would be able to meet the unique needs of their market. And this rule would have taken away some of that authority. The rule also would have stripped eligibility for tax credits from dreamers, so those who were eligible under DACA. There were about 10,000, I think, dreamers enrolled in this marketplace coverage who now are no longer eligible because of this rule. A lot of what the Trump administration was doing and what they wrote in the rule is they wanted to put, what they saw as program integrity measures in place. So they were very worried about alleged fraud and abuse of the program based on some data in 2023, I think, and some in 2024. And a lot of that, their concerns were linked to these enhanced premium tax credits that we're talking about, which is going to be important to the next few things we discuss. Given how sweeping and quickly this rule was to go into effect, I personally don't find it that surprising. It was challenged in court. And so you had two separate coalitions challenge the rule under the Administrative Procedure Act. There was one successful case in Baltimore, successfully stayed major parts of the rule. I have an asterisk next to just some of the parts of the rule that were stayed. There was also a separate lawsuit filed by 21 Democratic attorneys general and governors in Boston. The court there disagreed with their arguments, and so the rule was not stayed, but many of the challenges were put on hold on a nationwide basis because of the court in Baltimore. And I'd be happy to get more into the details of that, but the TLDR of that is that many of the most significant changes that the Trump administration had planned for 2026 ultimately did not go into effect because of this litigation. I still expect them to come back and try to do some of these again, so we'll see. And so shifting from sort of the White House and the agencies over to Congress, this has already been mentioned once before, but the One Big Beautiful Bill Act, I will call it HR 1 because that is too much to keep saying over and over again. But this was an incredibly sweeping law that President Trump signed on July 4th. Cuts about $1 trillion out of Medicaid, about $280 billion out of SNAP. There's a whole bunch of other changes that are not on the screen, but I think keeping our focus today on the changes to the Affordable Care Act and to Medicaid, very similar to the rule I was just talking about, you can see a lot of changes around eligibility, paperwork. I think across both of these programs, there have been a lot of changes to really put up red tape and put more administrative burdens. I think speaking from your own experience, but also from the literature, the more friction you create in the healthcare system to make it harder to enroll in and maintain your coverage, the more likely you are going to see coverage losses, which I know is something Dr. Mantell is going to discuss. But you can see those kinds of friction points and administrative barriers and red tape being put on both Affordable Care Act coverage and Medicaid coverage. So, new paperwork burdens, prohibiting automatic re-enrollment. There's a huge focus on eligibility for immigrants. To be very clear, no one who is undocumented qualifies for either of these programs. And there have been what we call lawfully present immigrants. So people who are in the country lawfully, think refugees, asylees, a whole host of other categories, were eligible for some of these programs. And across the ACA, Medicaid and CHIP, and Medicare, that eligibility was eliminated. You also saw the expansion of health savings accounts, which is a huge sort of hot topic right now, and some clarifications around the ability to use telehealth and direct primary care arrangements with high deductible health plans. So happy to get into the weeds if anyone's interested. Shifting to Medicaid, even more significant changes here. The ACA's changes were big, and Medicaid, they're even more significant. So I think about these in two categories. You have changes to Medicaid coverage requirements, so more of that red tape and administrative burden that I mentioned, mandatory work requirements, more frequent eligibility determinations, meaning people are going to have to submit paperwork on a more regular basis. New copays, so Medicaid beneficiaries who are above the poverty line, right above the poverty line, will be asked to pay $35 for certain, physician visits and other healthcare. That might not sound like a lot, but I think it's quite a bit when you're very low income, and so that's going to make it hard for people to access care. Limits on retroactive coverage, which will make it harder for hospitals and other healthcare providers to, recoup payment or reimbursement for services, which will lead to more uncompensated care. And those are just some of the coverage requirements. Those were the ones I thought most important to point out, but there's many others too. The second big category of changes under Medicaid is to financing. So the law include, and I'm so not an expert on this, we can try to answer questions. I'm sure my colleagues are, but really the bill really restricts the ways that states can raise revenue using what we call healthcare provider taxes to finance their share of the Medicaid program. Most states use this mechanism to fund Medicaid, and so without the ability to rely as heavily on this mechanism, it's going to strain state budgets even further. And we're entering an environment where many state budgets are already strained, and so you've started to see states look around to either try to raise revenue in a different way, to cut eligibility for benefits for Medicaid, or to cut benefits themselves. And that's the environment I think we're entering into there. There's also some new waiver programs for things like home and community-based services. So I have not harped on this. I'm not going to talk about everything here, but everything I just mentioned about HR 1 or One Big Beautiful Bill Act, very important to understand that these requirements really phase in over time. And so the work requirements don't technically start until 2027, but states are working towards those. Some of the provider taxes I mentioned start in 2028, although some start earlier, depending on where you are. There's a whole range of changes there, and things like the $50 billion Rural Health Transformation Fund, which is designed to offset some of the shifts in Medicaid funding, but actually starts earlier. That program begins in 2026, whereas you won't see some of the cuts to Medicaid until later. And so I think really, really important to understand how all these changes might be phasing in over time and sort of the burdens coming down the road. So federal officials are going to have to give guidance or regulations to implement all these changes. States are going to have to, review, weigh in, build, eligibility systems, update systems, inform enrollees and regulated entities. So for those with us from insurance companies, from healthcare providers, from organizations that assist consumers, are also going to have to adjust to all of these on a different timeline. And so again, when we think about where we are in 2025 and then look at this shifting landscape, I think it's really important to keep in mind how these timeframes exist in a staggered way already, but could shift over time as well. And this is my last substantive slide, and you heard Professor Yanda mention this already. I think it is important to talk about congressional inaction as well. So right now, coming to you live from Washington, D.C., this is the active fight over whether Congress will extend these enhanced premium tax credits that people have had access to since 2021. It's more generous financial help at all levels of the income scale and eliminated what was a prior payment cap that limited eligibility for those at 400% of the poverty level. Right now, if Congress does not act, all of those changes will go back into effect, and it's really going to harm. Many people will experience what feels like a doubling of the premiums that they are responsible for, but the people hardest hit will be older, middle-income adults in rural areas, because that is where healthcare premiums are the highest, and so that's something to keep in mind. You can also see some of the other statistics there. I think I'll hold off until Q&A, but right now in Washington, D.C., there's a lot of different ideas being thrown around to try to come up with bipartisan solutions about how you could restructure these subsidies, or how, could you add new caps? Could you make them less generous? What other types of restrictions should be placed on the coverage in order to make it viable? So from, again, peak enrollment, peak popularity, to a whole lot of uncertainty and shifting timelines. And with that, that is what I wanted to preview for 2025. And with that, I will turn it over to Dean Baines. Thank you.
Thank you, Professor Keith. The one big, beautiful bill is, we talked about that again. So we'll be talking about it over and over again, it seems like. Thank you so much for your concise and very interesting analysis of our current situation. Next up, I'd like to introduce my colleague, Jessica Lynn Mantell. Professor Mantell is the Hunton Andrews Kurth Professor of Law at UH, and she is a professor of law, and she currently serves as a co-director of the Top 10 Health Law and Policy Institute at the University of Houston Law Center. Prior to joining UH Law faculty, Professor Mantell worked as a senior attorney in the Office of General Counsel for the Department of Health and Human Services. In that position, she advised Centers for Medicare and Medicaid Services on legal issues dealing with Medicare matters, including implementation of the prescription drug benefit, hospital payments, incentive payments for the adoption of electronic health records, and healthcare reform. Prior to her service with government agencies, she practiced as an associate in the healthcare department of the prestigious law firm of Ropes and Gray in Boston, and clerk for the Honorable Karen Nelson Moore of the U.S. Court of Appeals for the Sixth Circuit. Her research interests include the impact on various legislation and regulatory schemes on emerging trends in healthcare delivery systems and the allocation of limited healthcare resources. She received her JD from Michigan Law School and her MPP from the University of Michigan School of Public Policy. Let's welcome Professor Jessica Lynn Mantell. Thank you.
Okay. Thank you, Dean. So I want to start with a core question that has shaped American health policy for decades. And it's the question of whether access to healthcare is a right, or should government healthcare be a safety net for the so-called deserving poor, or a benefit that has to be earned? So that question really underlies almost every debate we have about Medicare, Medicaid, and the ACA. And it's been reignited by the new Medicaid work requirement provisions in H.R. 1. And I'm also going to refer to the One Big Beautiful Act as H.R. 1 because, like Katie, I find the acronym OBBBA just too much of a mouthful. So from the beginning, U.S. health programs have tried to balance these competing ideas. When we ask who deserves publicly funded health care and on what conditions, we're really revealing the values we want to prioritize, like individual responsibility versus collective obligation. So over time, this has given us three basic ways of thinking about government assistance. One focused on the deserving poor, the second on earning public assistance through work or social contribution, and the third that treats healthcare as a universal right. So the first paradigm, the deserving poor, reflects the traditional idea that we should limit aid to those deemed worthy of help, or people who are poor through no fault of their own. So we're talking about people who can't support themselves through work, like the elderly, the severely disabled, and children. The deserving poor paradigm also rests on the belief that poverty results either from misfortune or from personal failing, and that only the former merits public help. So this view is skeptical of helping able-bodied adults. Over time, a second philosophy took hold, the earned benefit or reciprocity model. And underlying this paradigm is the idea that public benefits aren't charity, but something people should earn through work or other contributions to society. So it emphasizes personal responsibility and self-sufficiency. Also underlying this model is the belief that government assistance encourages dependency rather than independence. Consequently, programs designed under this logic often include conditions like work requirements. The rights-based model moves in a different direction altogether. It treats healthcare as a basic human right, something you deserve based on need, not moral worth or work history. So it emphasizes values like equity and collective responsibility for all citizens. Now, these three ideas are in a constant tug of war in the political arena, and they're essential to today's discussion about Medicaid. The deserving poor and earned benefit paradigms had a big impact on the Medicare and Medicaid programs as originally designed. So Medicare is really a hybrid of these two paradigms. First, for most Americans, Medicare is an earned benefit. You or your spouse pay into the program through payroll taxes, and later in life, you receive the benefit you've earned, Medicare coverage. But for people who qualify through disability or chronic conditions like end-stage renal disease or Lou Gehrig's disease, it's closer to the deserving poor tradition. Granting Medicare coverage to these individuals recognizes that they cannot work through no fault of their own, and society therefore has a moral duty to help them. Medicaid, on the other hand, grew out of categorical ideas of deservingness. It wasn't built for all low-income people. It was built for specific groups seen as especially vulnerable, like low-income children, pregnant women, the elderly in nursing homes, and people with disabilities. So this set up firm boundaries that excluded from Medicaid those considered capable of self-support. So in both programs, then, the original logic was to reward work and offer help to those who couldn't provide for themselves. In contrast, the Affordable Care Act was an ambitious effort to shift American health policy towards the rights-based model of healthcare. Specifically, the ACA made coverage depend on income alone, not on moral worth or work history. And it did this through two main pillars that we've been talking about. First, as Katie and Ken explained, the marketplace exchanges offer sliding scale subsidies that make insurance more affordable. Second, the Medicaid expansion extended eligibility to all adults with incomes up to 138% of the federal poverty line. And with this expansion, Medicaid no longer was limited to categories of low-income individuals deemed just deserving of help, but now included all low-income individuals. So the ACA aimed to make affordable health coverage a basic entitlement of citizenship. Now, some of you may be wondering why Congress decided to cover the lowest income adults through Medicaid rather than the marketplace exchanges. And one reason for this decision was that many states had already expanded their Medicaid programs to cover at least some low-income adults using state-only funds. So in these states, the necessary infrastructure for covering this population under Medicaid was already in place. In addition, including the lowest income adults in the exchanges would have raised premiums for others, since this population tends to be sicker and higher risk. Now, the ACA vision of health coverage as a universal right was undercut in 2012 by the Supreme Court's decision in NFIB versus Sebelius. So as Katie mentioned, in NIFB, the court held that Congress could not compel states to expand Medicaid by threatening them with the loss of all federal Medicaid funding, as this violated principles of state sovereignty under the 10th Amendment. So this then made the Medicaid expansion optional for states. Since then, the debate in the states over whether to expand Medicaid has mirrored the philosophical tensions I discussed a moment ago, whether healthcare is a right or whether it's a reward. So as Ken mentioned, 40 states and the District of Columbia have adopted the expansion, but 10 states, including Texas, have not. And policymakers in non-expansion states have justified their choice by appealing to values aligned with the earned benefit and deserving poor paradigms, like personal responsibility, skepticism towards federal dependency, and fiscal prudence. In non-expansion states like ours, the result is the coverage gap that my co-panelists mentioned. So the poorest adults, so those with incomes below 100% of the poverty line, these individuals often remain uninsured because they don't qualify for Medicaid, and they also do not qualify for marketplace subsidies because those start at 100% of the federal poverty line. So this brings us to the new rules in H.R. 1, which mark a clear return to the earned benefit and deserving poor paradigm. These rules condition Medicaid coverage for low-income adults on their participation in work or related activities. Specifically, the work requirements apply to adults ages 19 to 64 with incomes at or below 138% of the federal poverty line. So Medicaid beneficiaries subject to these requirements must complete at least 80 hours per month of a qualifying activity like employment, job training, attending school, or performing approved community service. Now, some groups are exempt, such as pregnant individuals, caregivers of young children, or disabled dependents, as well as those that are deemed medically frail. Now, I want to note that for us here in Texas, since we've not expanded Medicaid to low-income adults, these rules will not have a significant impact on our current Medicaid program. But they are an essential part of the national policy debates and are highly relevant to any future discussions about coverage expansion that we might have here in Texas. A critical piece of these new rules is a verification process. States must verify an individual's compliance when they first apply for Medicaid, and then at least every 6 months, although states can elect to verify compliance more often, such as quarterly or even monthly. While states can use databases to verify compliance, many people, like those doing seasonal work or students, they're likely to have to submit documentation, as databases do not necessarily have complete information on their employment or education status. So states are expected to implement these work requirement provisions and the verification processes by the end of 2026, although extensions are possible. So the result of all of this is a new national split on access to healthcare. For those getting subsidies on the ACA exchanges, no work requirements apply, but for our lowest income citizens in expansion states, coverage will now be contingent on their verifying that they meet these work requirements. And some commentators have observed that this means for some individuals, access to affordable healthcare will function as a right, but then for the lowest income individuals, it must be earned. And I just want to mention that according to Congressional Budget Office estimates, the Medicaid work requirements could lead to 1.5 to 2 million fewer people enrolled in Medicaid nationwide over the next decade. So let's look at the policy debate around this. And as we'll see, these arguments map directly back to the three paradigms that we started with. Supporters' arguments draw heavily from the earned benefit tradition. Their primary argument is that the new requirements encourage able-bodied adults to work or get training. So supporters see the work requirements as a path out of poverty to self-sufficiency, ultimately reducing long-term dependency in public programs. Proponents also link work to health. They cite evidence that people who work tend to have better physical and mental health, and they therefore argue that encouraging workforce participation improves individuals' overall well-being. Proponents further argue that Medicaid's core mission is to serve the most vulnerable, so children, the elderly, the disabled, and trimming eligibility for able-bodied adults could be working, who could be working, protects the program's fiscal sustainability for those that allegedly need it most. Finally, proponents point to other programs like SNAP and TANF that already have work requirements, and they argue that extending these requirements to Medicaid aligns Medicaid with the rest of the safety net. And they further argue that it's unfair for taxpayers to subsidize healthcare for able-bodied adults who are not working. Opponents of the work requirements obviously disagree with many of these arguments. So their arguments fall into two main buckets. The first is a philosophical objection based on the view that healthcare is a right. So many critics view the work requirements as a step backwards from the Affordable Care Act's rights-based vision of affordable health coverage as a basic entitlement of citizenship. And they argue that access to medical care shouldn't hinge on your employment status. Second, critics argue that in practice, the work requirements may actually undermine its own stated goal of self-sufficiency. Opponents of work requirements say that people often need stable health coverage first to be healthy enough to get and keep a job or attend school. So they are concerned that losing health coverage could lead to deteriorating health, which then makes it harder to work or go to school. So this argument really flips the logic of proponents who contend that the causal arrow points in the other direction. Critics also note that roughly 9 in 10 adults in the expansion population are already working or are in school or they're caring for a dependent or they're disabled. And they are concerned that people who do in fact meet the work requirement will lose coverage for procedural reasons, like missing a reporting deadline or being unable to get the right paperwork. For example, it may be difficult to document 80 hours of work if you're a day laborer or a house cleaner or a gig worker and you don't have a formal payroll process. And for those that suffer short-term disability, some may have trouble getting the detailed medical paperwork necessary to document their disability. Finally, opponents point out that building these new verification systems, training staff, and handling an appeals for all this is going to be very expensive for states. Costs that they could maybe spend on actual health services. So opponents fear that the complexity of the rules and the verification process could lead to delays in the state's verification processes or data errors, and that could result in delayed enrollment or improper disenrollments. As for how this might actually all play out, we have a couple of real-world test cases from Arkansas and Georgia. In 2018, Arkansas implemented a work requirement for adults ages 30 to 49 in the Medicaid expansion population. So these individuals had to report at least 80 hours per month of work or other qualifying activities like job training or volunteering. And enrollees had to report their activities each month through an online-only portal. Missing the reporting deadline for 3 consecutive months led to automatic disenrollment from Medicaid for the remainder of the calendar year. So within the first 6 months of the Arkansas Work Requirement Program, more than 18,000 people lost their Medicaid coverage. So that's about a quarter of those that were subject to these new rules. And researchers who studied this found that many of those who lost coverage were actually working or they qualified for an exemption. So the researchers found that a lot of people simply struggled to navigate the online reporting system, or they had limited internet access, or lacked digital literacy. There was also widespread confusion about who was subject to the requirements, how to claim exemptions, and how to verify compliance. Follow-up studies also found no evidence of increased employment among the target population. In addition, healthcare providers reported an uptick in uninsured visits and delayed care, particularly for those with chronic conditions. A federal court ultimately halted the Arkansas program in 2019 after concluding that the policy was inconsistent with the Medicaid statute. Georgia's experience is more recent. As a non-expansion state, Georgia launched a limited program in 2023 to offer coverage only to low-income adults with incomes below the poverty line who could prove that they were working 80 hours a month or going to school or performing community service. So early implementation went along pretty slowly with this program. By early 2024, only about 3,000 people had enrolled in the Georgia Pathway program, whereas the state had projected more than 90,000 people would enroll. Analysts again pointed to documentation burdens as a barrier, such as difficulty verifying hours among those with irregular work schedules or intermittent employment. State agencies also face challenges in developing the necessary reporting data systems. So how do we interpret this evidence? Well, supporters of the work requirements look at these challenges and they see growing pains. They argue that as with any complex program, there will be early implementation challenges, but with more time and better data systems and more public education, they believe states can overcome these issues. Critics, however, not surprisingly, interpret the same evidence differently. They argue that the experiences of Arkansas and Georgia show exactly what they fear, that the policy creates administrative burdens that cause large coverage losses without producing any measurable workforce gains or health gains. And some critics go a step further and argue that the work requirements are not really about promoting work, but instead are meant to reduce enrollment in Medicaid. So they argue that that the work requirements are intentionally creating administrative and procedural barriers to Medicaid enrollment to indirectly shape how many people participate in Medicaid, rather than using explicit eligibility cuts that would be more politically visible, but perhaps less popular. So in this view, the work requirements aren't just about promoting work. They also function as a hidden mechanism to redraw the boundaries of who is deserving of public help. Now, to be very clear, this interpretation is controversial. Supporters strongly reject the idea that the ultimate goal is to shrink coverage on Medicaid. Rather, they emphasize the goals of self-sufficiency and conserving limited Medicaid resources. But the persistence of these two very different narratives, one about independence, the other about administrative rationing, brings us full circle to the question that we began with, which is whether we see healthcare as a right, a responsibility, or something in between. So the choices we make about policies like work requirements ultimately is really about expressing what kind of social contract we want to have here in the United States. So with that, I will send things back to Dean Baines.
Professor Mantell, thank you for that very comprehensive conversation of putting all these things in place. It'll be great for us to talk about some of that during the roundtable. Next, I'd like to introduce our final expert, who's Dr. Brian C. Reed. Brian Reed is a practicing family physician and chair of the clinical science department at the Tillman J. Fertitta Family College of Medicine. He completed his undergraduate studies and medical degree at the University of Michigan. He returned to Houston and joined the faculty of Baylor College of Medicine and Harris Health System. During his 16-year tenure at Baylor, Reed held various positions at Baylor and Harris Health System, including medical director of the Harris Health System Gulf Gate Community Health Center, assistant chief of staff for Harris Health System's ambulatory care services, and vice chair and interim chairman of Baylor's Department of Family and Community Medicine. Prior to joining the Fertitta Family College of Medicine, he served as a division director of disease control and clinical prevention at Harris County Public Health. At Harris County Public Health, he served as one of the lead physicians at the NRG Stadium Hurricane Harvey Shelter. Dr. Reed is committed to educating the next generation of healthcare professionals about the care of the underserved and the social determinants of health. Let's welcome Dr. Brian Reed.
Hey, good afternoon. Thank you for the invitation. I absolutely love this topic. Give me a moment while I share my presentation. Okay. So as we teach at the medical school, we usually begin with the population health framework, and it kind of codifies why we're there. Our aims are typically in healthcare to improve population health outcomes. So we want people to have long lives, so improving the population's mean mortality, as well as their quality of life. So we are looking at, ways in which we can improve longevity as well as quality of life. And we want to try to eliminate disparities. So we don't want to have situations where we have an intervention and we're leaving populations behind. We don't want to leave people behind because of race, ethnicity, socioeconomic status, geographic location, or sex. And what we've come to understand is that there are several non-medical drivers of health that have a big impact on people's mean mortality or how long they live, as well as the quality of life. So this discussion today really sort of talks about, some of those policies and interventions that impact people's access to medical care. In addition to that, we think about individual behavior, how much people smoke, how much people drink, the lack of physical activity, social environment, physical environment, and genetics playing a role in this, but today's discussion focuses really sort of on policy interventions and how they may impact mean mortality and quality of life, specifically the ACA. There's examples all around us of policy interventions affecting health. So, I'm a child of the 70s, and, you used to go to restaurants and people could smoke. Now you have to go to the moon if you want to have a cigarette due to ordinances. Drinking and driving, you can't, drink and drive. There's DWI laws. Seatbelt laws have definitely improved safety in terms of the automobile and decreased automobile accidents and fatalities. And then here is an example of the ACA's impact on our restaurants and an attempt to try to curb the obesity epidemic by displaying the amount of calories in foods. This didn't just happen organically, it was legislated into some of the large chains of restaurants. It takes a long time to usually measure the impact of health policy interventions. Disease processes require time. It takes time for cancer to develop. It takes time for heart disease to develop. It takes time for diabetes to develop. And causes of most chronic diseases are multifactorial. So it's oftentimes hard to attribute, this intervention has led to this disease or that disease. An example of one intervention that did lead to some health impacts that were relatively quickly identified was the Flint water crisis. So what happened at that time, back in 2013, there was the decision to change the source of water from Detroit to the Flint River. And about a year later, we started to see some health impacts. People complained about the color of the water because the Flint River had been used as a sort of disposal area from the auto refineries, and they were concerned about the quality of water. And public officials assured them everything was okay. Then we started having cases of E. coli and Legionnaires about a year later. But it wasn't until really 2 years later where the state recognized that there had been increased reports of lead in children's blood levels. And unfortunately, lead poisoning can cause irreversible neurotoxicity and lifelong damages. And, the long-term outcomes of this intervention still are being evaluated. So it has taken us some time to understand, what all the health impacts of the Affordable Care Act have meant. The Affordable Care Act went into effect in 2010, and of course there was legislation throughout really sort of impacting how it's been implemented, and we've seen variable implementation across the states. But we have started to see that using death certificate data, so looking at county level data and looking at life expectancies in different counties, we've started to understand that in those states that have expanded Medicaid, they have had fewer deaths compared to those states that did not expand Medicaid. Now, those states that did expand Medicaid already had a head start. We've had some discussion or had some beliefs within healthcare and within public health that your zip code may be, in fact, more important than your genetic code. And some of the environments in which we grow up and the opportunities and access to healthier foods and things, shape those sort of outcomes, as mentioned on the first slide. So we see here that those expansion states already had sort of lower deaths per 100,000 individuals, and that gap sort of grew throughout the implementation. And we've seen actually larger impacts amongst certain communities. So particularly among the non-Hispanic Black communities that had previously not had access to Medicaid, or some of these expanded tax credits, as well as individuals living in rural areas and some of the Hispanic populations that had been previously uninsured until these interventions took place. Their mortality actually was further reduced when compared to this. We've seen improvements in some of the health impacts in terms of cardiovascular risk. So here, lower systolic blood pressures in states that have expanded Medicaid. The diastolic blood pressure is about the same. Diabetes control has been a little bit better. So lower hemoglobin A1Cs, which is one of our markers of how well people are controlling their blood sugar for the 3 months prior to a physician's visit. Cholesterol levels, the LDL cholesterol level is one of the biggest risk factors for heart disease. We've been demonstrated to be lower amongst those states where they had expansion. Triglyceride levels also lower. And then a good cholesterol level increased in those areas where there's been expansion. So, if we were to sort of watch these things play out over time, it would be anticipated that this would lead to fewer cardiovascular deaths. But another part of the story is not just the health outcomes, but really sort of the economic impacts of having access to healthcare and job creation related to these Medicaid expansions, as well as it's having this benefit. So when they have discussions about healthcare, I always wish they would have greater discussion about how it would impact the jobs and the economy. We've seen a shift in our economy, and we've become less involved in manufacturing. That's been a long decline, but we have seen rises in healthcare, and healthcare now is about 13% of the workforce. And we've seen that most states, one of the top employers, if not the top employer in the state over time, has become healthcare. So it's not just physicians, it's not just nurses, but we think about people working in pharmacies, people working in the hospitals, people working in the industry, in insurance industry. So I mean, it's massive, the amount of jobs that are linked to healthcare or healthcare adjacent. So it can't be underestimated the potential impact to the economy by changes in how we pay for healthcare. Many hospitals actually have pretty slim margins, and what we find is those hospitals that tend to serve rural and urban areas tend to have larger percentages of Medicaid and, unfortunately, larger percentages of negative margins. So meaning that they operate maybe -2, -3% annually. So they're losing money by providing care. And oftentimes they work within a system or have a system of hospitals, and they're getting subsidized by some of the more profitable ones. So there's a lot of hospitals in the United States that are about 40% have negative margins in 2023. So there's a lot of hospitals that are at risk if we have further shrinking of these margins or further shrinking of the reimbursements for the care that's rendered in the hospitals. An issue brief that was recently released for the Center for Healthcare Quality and Payment Reform estimates that about 21 hospitals in Texas, mostly in rural areas, are at immediate risk for closure. The idea that a hospital will always be there and provide services to the community is really a fallacy. And I think it's lost on individuals that, yes, hospitals and medical clinics are businesses, and they do close at times. We've seen since 2010 through to 2023 more hospital closures than openings in the United States. And we have several hospitals, or multitude of hospitals that operate with negative margins, as mentioned before, about 40% of them, and some with greater than 10% losses. So their long-term viability is definitely at risk. And before we transition to the roundtable, I want to just share a little bit of a personal story and why this is so sort of relevant to this discussion. So I share this discussion about Mercy Hospital in Detroit. And this hospital closed about 25 years ago. It's similar to some of the hospitals that we mentioned on the previous slides. It served urban area, largely indigent area on the east side of Detroit. It is the site of my residency. So after graduating medical school in 1999, very excited to start residency. And 6 months into my residency, the hospital closed. I learned a valuable lesson around health economics at that time, that there's no margin, there's no mission. Mercy Hospital was losing about $2.5 million per month, and it was just unsustainable. There had been some changes to the way in which Medicaid had been reimbursed in the year prior, as well as some caps at the federal level, and unfortunately, it just was unsustainable. So the hospital closed. I was fortunate enough to be transitioned to Henry Ford's main campus in Detroit to complete my training. There were about 1,300 jobs lost when the hospital closed. So, definitely challenging when we lose a hospital. As a frontline worker and seeing patients in uh, a clinic that is geared towards trying to take care of individuals regardless of regardless of the ability to pay. We have a UH Family Care Center, which is a federally qualified lookalike. So we see patients on sliding scales. So if they don't have insurance, we're able to work out an arrangement to where they're able to pay a portion. I see several individuals that have marketplace insurance. Many of them are independently employed. I see several lawyers at my practice in addition to indigent individuals that are on Medicaid. And there's a great deal of concern about rising premiums. My December is booking up rapidly as people are pouring in, trying to ensure that they're able to at least have refills and get the last of their care before they lose their insurance, assuming they're not able to pay for the increased premiums in the coming months. So with that, I will stop sharing and close.
Thank you, Dr. Reed, for a very comprehensive conversation. I'd invite all the other panelists back for our roundtable discussion. So my first question to all of you is, how do the original policy goals of the ACA compare to the reality of what's been achieved? So we had talked a little bit about, the pre-existing conditions, the Medicaid expansion, the kids up to 26, the children up to 26 being on the parents' insurance. Do you think it has lived up to its expectations? No one wants to go first?
I'll go first.
Rasianda.
Yes and no. So, it certainly has decreased the number of people who are uninsured. It has increased, it has improved health outcomes for the country. And it has made health insurance affordable for people who previously could not get insurance because of pre-existing conditions and those kind of things. The one disappointment that I've had, and I think that some policymakers have the same one, is that it hasn't done as much as I would have hoped that it would do to actually control the rate of increase in healthcare costs. So the United States still spends about 18% of GDP on healthcare, and that number has been holding steady for about the last 10 years or something like that. So we haven't actually seen costs go down. The gross premium insurance premiums continues to go up, and that means the subsidies keep going up. And so the federal government it's costing more money as more people sign up and the amount of subsidies are higher. So that's been the one area that I wish we could have attacked more directly.
Yeah, I'll just echo those comments. I mean, I think the primary goal of the Affordable Care Act was coverage expansion. And as we've been talking about, there's been certainly some success there. But a criticism that you often would hear about the ACA was that it didn't do anything to bend the cost curve, meaning didn't do anything to slow overall healthcare spending in the US. I actually disagree with that allegation. The ACA, which a lot of people don't appreciate, made a lot of changes to how Medicare pays healthcare providers. So the ACA adopted under Medicare various payment programs that link payments to providers based on how good a job they do monitoring healthcare spending. And it's important to note that while these were payment changes made under Medicare, there was an expectation that there would be a spillover effect to the rest of the healthcare system, because as a provider, you're not just going to change how you take care of your Medicare patients. You're going to change then how you take care of all your patients. So these results of these programs have been mixed. There's been some success. So in the early years, we did see some moderation in healthcare spending, and we certainly saw improvements in care coordination and the quality of care. But I agree with Ken that long-term national expenditures are continuing to rise at rates faster than the general inflation rate. So certainly a lot of room for improvement. So I think the bottom line is that the ACA did have a lot of success in coverage expansion, but not so much success with cost containment.
And
Those are keys.
I would only add that I think the Affordable Care Act, as written and passed by Congress, did have some of those mechanisms, but they were repealed on a bipartisan basis
Yeah.
over time. Things like the Cadillac tax, things like the Independent Payment Advisory Board. There was lots of bipartisan support for repealing the things that were going to pull down costs, which I would sort of lay at the feet of private interest. The other thing on the coverage expansion that I think is interesting is there's often a lot of criticism of the Congressional Budget Office, which is sort of, Congress's economists. They do the projections of how much things are going to cost, how much people are going to gain in coverage. It has taken longer than they expected to achieve the gains that they predicted. So back in 2010, when the law was passed, the CBO predicted we would have 24 million Americans covered through the marketplaces in 2019. That was not realized until this year, as we've been discussing, and I think it's thanks to those enhanced premium tax credits. They also underestimated the Medicaid expansion enrollment. I think even with the shift to optional. So I think also an underestimate of maybe how many low income people, even lower income people, I should say, would come to rely on the changes under the Affordable Care
Could
Act.
you explain Cadillac tax for those of us who may not know what that is?
Oh goodness.
Briefly.
Yes, it's
Briefly.
been in the recesses
Wow.
of my brain, and
Briefly.
others should chime in. The idea is that it was a disincentive for what we call the sort of Cadillac employer benefits that you might get. So the most generous, because of the tax exclusion that applies, people don't always think of it this way, but when you get job-based coverage, your employer and you get sort of a tax write-off for that. It's being subsidized through your employer. And maybe if you did not have such generous health insurance, you'd be getting paid more. But I think it's a misnomer that people with job-based coverage aren't getting help. The idea was that no one should have access to the most generous, the most comprehensive sort of Cadillac coverage that's being subsidized by the taxpayer. And I can't remember all the fine points of exactly how it was limited,
No,
but it
that's
was
helpful.
if your generosity of your employer plan goes above a certain level, it was capped there. When I say special interest, in that case, labor unions, some employers didn't like it. And again, I think banded together to have that provision repealed. But others should
Dr.
please weigh in too.
Well, the
Dr.
big problem with it was based on the cost of the insurance program, and if it exceeded a certain amount, that the Cadillac tax would kick in, and didn't really do a very good job of taking into consideration that some employers have higher costs because they have sicker, older employees, and so it was, and the evidence is less and less that having skin in the game in terms of people having more cost sharing, which would lower premiums for the employer, that actually reduces utilization. It doesn't seem to really do that.
Dr. Reed, do you have any thoughts on that question? These questions, not necessarily the Cadillac tax, but whether
No,
the ACA
yeah,
is effective or not.
yeah. No, so as someone that's worked, mostly in safety net organizations, so places that are supported with local tax dollars and county facilities dedicated to the care of underinsured, I thought it was a step in the right direction, and we really sort of a dream that's still unrealized to where we would have better access for everyone.
Okay. Do you think the challenge is that we've relied sort of on the private market insurance companies? Do you think that might be the issue, or that not just like you, but generally? I mean, I think I hear that as like one of the criticisms of why it's not affordable is that we have business interests who are involved and insurance companies involved. I don't know. I mean, I'm just curious. That's what I hear. I'm not an
I would
expert
say the insurance companies are one of the players involved, and certainly bear their share of that. And as a recovering health insurance executive, I can say that most certainly. But it's also hospitals and pharmaceutical manufacturers and a lot of other, for-profit businesses that have driven higher prices. And so, the reason why health insurance is so expensive in the United States is primarily because we pay the highest prices for all services. including physician services. Of course, as Dr. Reed would probably point out, that's because it's a very expensive proposition to go to medical school, and they come out with a lot of debt, and there's lots of reasons for why physicians get paid what they do, but it's across the board, the whole industry, privatization. And that's, I think, probably the biggest challenge with the ACA. It was built on leaving all of those things in place that were in place. And so we really have a bit of a Frankenstein monster health system in the United States. These things all pull together.
I see others shaking their head. Agreement? Okay.
Yeah, I mean, I would reframe the question slightly to be less about private insurers who may be often for-profit businesses, and more with what Professor Yanda was saying at the end. We were building this on a market-driven system of healthcare. So, as I mentioned with the Affordable Care Act, and really even since the Affordable Care Act, we've been focusing a lot more on alternative payment models. And that's in recognition that payment shapes provider behavior and investment decisions, and just a recognition that how we traditionally paid providers, where we gave them a fee for each service, regardless of how good a job they were doing, holding in costs or improving quality, that's a big contributor to the problems of our healthcare system. But when we have this market-driven model where we have payers all sort of doing their own thing, it means at the provider level that you are operating under multiple contracts with different payers at the same time. Some are still largely fee for service, but some are doing these alternative payment models. And it's resulted in this misalignment of payment incentives across payers, because each payer has their own rules, their own financial incentives, their own performance benchmarks. And as a provider, you're simultaneously navigating all these different payment arrangements. And for a lot of providers, that's just operational overload, right? Especially for smaller and medium-sized providers. And it's even more complicated when the financial incentives under these different arrangements might be pointing in different directions. And so that can really dilute the impact of what each payer is trying to achieve with these different payment models. But I think there's other challenges that kind of reflect this idea that we're relying on the market, and that we don't have a robust enough health data sharing infrastructure, which makes it a lot more difficult for providers to succeed under these alternative payment models and shift to what we call value-based care, which is very dependent on having timely and comprehensive patient data. For value-based care to succeed, we need more primary care providers and behavioral health providers and care coordinators and community health workers. We have shortages of all those. And then I think just for a provider, shifting to value-based care is hard, resource intensive, and many providers don't have the resources or know how to do that on their own. So they need payers and the government to help them. But to sort of bring this back to where I started, is that these structural barriers really can't be solved just through marketplace competition. And so I think if we continue with this decentralized, uncoordinated approach, where we have payers just on their own experimenting with different payment models, it's going to be really hard to produce the payment alignment and the infrastructure needed to shift to value-based care, and ultimately to bend the cost curve as we're trying to do. And so I think that we need to rely a little bit less. I'm not saying eliminate the marketplace, but maybe be a little less reliant on just the marketplace and have a bigger role for coordinated, centralized governance. And I sort of envision the government bringing stakeholders to the table, either virtually or literally, to kind of jointly develop policies that align their payment approaches and build the necessary infrastructure and help providers transition to value-based care. But to end on a little more positive note, there are some states, and this is both red states and blue states, that are actually doing this, and I think trying to move away from just relying on the market and to take a more coordinated approach to address these barriers.
I hate to pile on to this one, but I just have to for a second, because it's
Okay.
not just the payers, but it's if you're a hospital in the revenue cycle portion of a hospital, you've got Medicaid, and if you're in Houston, you've got 5 different Medicaid plans. You've got Medicare, traditional Medicare, you've got Medicare Advantage with about 10 different Medicare Advantage plans. You've got commercial insurance, fully insured. You've got large self-funded employers that have their own rules. The administrative and regulatory burdens that all providers face is just astronomical. And I'm definitely in with Professor Mantell's idea that we need to come together to figure out how to make the system simpler, which will then allow us to change some of the financial incentives in the payment models. But right now, they work at cross purposes, and what a hospital needs to do to be successful in Medicaid is different than what they need to do to be successful in Medicare, which is different than what they need to do to be successful in employer-sponsored insurance right now. And that's a hard place to be in. Not to take up for the hospitals on this, but it is a challenge that they have.
Yeah, let's move to the next question. So when it comes to HHS regulations under the ACA, it seems like each administration has seemingly reversed many of the prior administration's policies. We've seen this with the rollback of some of the Obama era rules. What is the cycle of regulatory whiplash, if I could call it that? Tell us about the stability and sustainability of healthcare reform in the United States. How does this regulatory pendulum affect insurers, providers, and states trying to implement these programs on the ground? So regulatory whiplash. Is there regulatory whiplash? Has there been regulatory whiplash? Inquiring minds want to know. Is there regulatory whiplash? I see people
I'm
shaking
happy
their
to
head.
start.
Professor Keith,
Yes,
why don't you go first?
there definitely is. And I think it's in part because of the congressional gridlock, right? Which means Congress has not made any changes to the Affordable Care Act over time. And so you have the same framework and different people coming in and reading the same law and trying to impose their different policy goals. And so what you see over time is what was first put in place in the Obama administration being reversed or taken in a different direction from, the first Trump administration, ditto for the Biden administration. And now you're seeing that with the 2025 regulation that I talked about. So the whiplash it's happened, I guess, 3 times now where the goalposts have moved, but I think it's because you're trying to leverage, the same language for maybe different regulatory and policy ends. In addition, I'll let my colleagues speak more about the impact on regulated entities and consumers. It is impossible. And even that was part of the litigation that I mentioned, where a rule at the end of June to go into effect January 1 was just impossible. And you had, state-based marketplaces and state regulators saying, we cannot possibly make all these changes you need us to make. And so those kinds of factors where you just cannot shift gears in the way that people are being asked to. And I think the point I wanted to make is about the litigation that it spurred. And so you have so much of the Affordable Care Act implementation is tied up in court cases too, which has also impacted the ability to sort of expand access, address equity, address transparency, and all these other goals too. So not only is it just taking the same language and trying to fit a need that your administration wants to, address, it's also trying to deal with all the pending court cases over all kinds of different issues that I think would be of interest.
And the court cases
to
actually
folks.
and as you point out, some of the court cases were existential to the act, right? So what does the market do? What do all these individuals do if they don't know whether this will continue or continue in this form over a period of time?
And all the uncertainty and all the thinking and all the planning and energy that has taken up in the healthcare system over the past 15 years to even when things have been fine, it's time spent not focused on fixing real problems like some of what Professor Mantell, but the rest of my colleagues have already pointed out.
Any other thoughts?
Well, certainly from the insurance company standpoint, a lot of discussion is if you just leave it alone and whatever it is, so that we have some stability and figure out what customers really want and how this works in balancing needs of providers against consumers. But when you're always in this state of flux and change, it's just really difficult. And I would say the same thing for doctors and hospitals and stuff too. It's like you know, it just like any other industry, there's real challenges when you have constant regulatory flux like we've had for the last 12, 15 years.
Well, businesses always require stability. They want
Right.
certainty. If they don't have certainty, that's a
Yeah.
big problem for any business in any industry.
Yeah.
Professor Mantell and Professor Reed, any thoughts?
Yeah, I mean, just to kind of echo what's been said, I mean, as an insurer, like as with any business, like you're making your decisions years out. Like, do I want to enter this market or exit this market? Do I want to change my product? Do I want to change my pricing strategies? Should I invest in some quality improvement initiative or change my administrative processes? And when you have the revenue uncertainty associated with the regulatory changes and all the litigation, it just complicates the ability to sort of project actuarially what might happen over the next few years, which complicates your ability to do strategic planning. And so that uncertainty can lead to less innovation and less risk taking in the insurance industry. I mean, insurers tend to just be cautious as a group. Um, and it could, in some cases, result in insurers leaving the marketplace exchanges or the Medicaid market, or not entering these markets. And that ultimately, we should recognize, reduces competition and the options available to consumers. And I think it's sort of a similar story with providers, right? Providers have revenue uncertainty given all these changes. And so they too will hesitate to invest in new staff or invest in new capital projects. So, similar story. And then just to comment a little bit about states, since you asked about that. I mean, states have to, in administering the marketplaces and their Medicaid programs, they have to build appropriate IT systems and verification processes and other administrative processes. And when you have these policy changes, they have to invest in retooling them. And that too can, it poses a cost on states. But I think there's also, I just want to, I don't think any of us have mentioned this yet, but states' Medicaid programs are a real source of experimentation and innovation in healthcare. There's something called Section 1115 waivers. They're called that because it's under Section 1115 of the Social Security Act, and allows states to seek a waiver from the Medicaid requirements to experiment with something new, something they think will improve care or improve access or lower costs. But when you have the potential for a reversal from administration to administration, where this administration grants the waiver, but this administration says no, that might stifle states wanting to seek these waivers and experiment in various ways.
Thank you. Dr. Reed, any thoughts?
Yeah, I look at it from the patient perspective. I mean, every year they're having to try to figure out which healthcare plan would be best to suit their needs. And with these regulatory changes, as different payers enter and exit the market and what's covered and what's not covered, I mean, it's pretty dramatic. I mean, I'll have the same patient for many years. One year this prescription's covered, next year it's not. This lab, I mean, it's very frustrating.
Right. So I think Professor Yanda raised this issue in his presentation. I think it was you about, the states had to have increased the Medicaid coverage or sought the Medicaid expansion, and those states that haven't, maybe it was, several of you meant, I want to reiterate that or revisit that. And so are the health outcomes better in those states that have expanded Medicaid and those that hadn't? And what are the costs involved? And why do you think that is? Do you think it's just because it's Medicaid, or do you think it's other things as well? And it's open to everybody, but I'll start with Professor Yanda.
Yeah. Well, there certainly are. You can, always have to say, correlation is not causation. Okay, so I will say that right off the bat. But there is a very strong correlation between worse health outcomes and the states that have not expanded Medicaid. Okay, there's lots of other things going on in those states, some that pull in different directions. So it's there's historical non-medical drivers going on in some of those states, historical biases against certain populations. There's immigrant issues. There's so many variations, but there's just this growing body of evidence in the studies and in the various report cards that have been done that show the correlation is very strong between those states that did not expand Medicaid. The more uninsured people you have consistently have more age-adjusted mortality, lower average lifespan, just a whole bunch of measures. But not just that, but how many kids have had a dentist appointment, how many women have gotten cervical cancer screening, and just on and on, no matter what measure you use, there's this strong correlation. How much of it is historical, how much of it is ACA related? I don't think anybody has tweezed that out exactly, unless Dr. Reed is aware of other studies on that. But
No, there's a lot of confounders, and unfortunately, many of those states that haven't expanded Medicaid already had worse health outcomes to begin with. I mean, particularly along the Gulf Coast, we've seen higher rates of cardiovascular disease in those areas, and a lot of it's related to lifestyle as well as poverty.
So one of the things I think, oh, good, Professor.
I was gonna say, I'll comment a little about the fiscal impact. So one concern that a lot of the non-expansion states cited was that the expansion would increase state budgets. But most studies of expansion states have found that the fiscal impact has either been neutral or there's actually been a net benefit to the states. And an important reason for that is because the federal government covers 90% of the cost of covering the expansion population, leaving only 10% of the cost paid for by the states. And so for states that haven't done the expansion, that's a lot of federal funding to forego. I mean, in Texas, we forego billions of dollars annually because we haven't done the expansion. And so while the federal government is bearing a lot of the cost, or most of the cost of the expansion population, a lot of the benefits derive to the state. So in states that do the expansion, it reduces state and local spending on uncompensated care. So some often uncompensated care is funded through local property taxes or hospital district levies or local subsidies. I mean, that's what we do here in Houston and elsewhere in the state. And then the expansion, I think, as Dr. Reed talked about, it strengthens rural hospitals and community clinics because they now have fewer losses due to uncompensated care. And that can generate a lot of just economic activity for local communities. It allows for expanded employment in the healthcare sector. And that in turn, that economic activity can lead to an increase in tax revenue. And so I think that's why the budgetary effect of states that have done the expansion has either been neutral or even positive.
just one more quick point on that. In Texas, we complain about high property taxes, and I remember in the throes of all this debate when I was working community health choice and part of Harris Health System, and the CEO went to the state legislature and said we could reduce property taxes in Harris County by expanding Medicaid. So if you think property taxes are too high, because Harris County Hospital District, takes in so much money to provide care to uninsured people, but yet the politics in a state like Texas were such that even though it would be a net benefit to the state, we can't get past what Jessica was talking about in terms of the deserving poor and is healthcare a right or not? So it's the states haven't expanded is much more politics and sort of these fundamental beliefs than it is about a pure economic argument.
This is not on the data, but I might add, I think the Congress in HR 1, they didn't repeal Medicaid expansion, but they almost did. The work requirements, there are so many of the different changes that were mentioned that really only apply to the Medicaid expansion population. I think that's why my colleagues have said it won't affect Texas that much. And so they didn't sort of sweep it all away, but I'm sort of deeply anxious and watching to see if you actually have some states who have expanded Medicaid, who look at this and think about all the, again, these like paperwork, red tape burdens they have to implement, the cost it's going to be to the states to set up this new burdensome system, and say, this just isn't worth it. Like, we're going to back away from Medicaid expansion. We'll do something else. I don't know how the finances work out, but I think Congress really did as much as it could to disincentivize Medicaid expansion in many states, despite the sort of not changing the, 90%, very generous amount of federal money flowing in. So I feel like that's a bit of an issue to watch going forward too. And of course, all the implications for health disparities and, everything else I think that we've been talking about in terms of outcomes themselves.
Dean, you're muted.
Can hear you, Dean Baines.
Sorry about that. Professor Mantell had spoken about like who deserves kind of health coverage. And so why does Medicaid, why does it remain this flashpoint about who deserves government-funded health coverage? How does this relate to the Medicaid work requirements? Because just for me, I think Medicaid work, I mean, if you working or not, if you don't have, I mean, it seems like you should have health coverage, but why are we tying it to work? And does it have anything to do with preconceived notions of who should get the coverage? Are there any preconceived notions of who should get the coverage, health insurance coverage?
Yeah, I mean, I can echo a little bit what I, said in my presentation. Like, it's just not just with Medicaid, but just welfare generally. Like, we have a long history in this country going back to like colonial times of linking welfare to whatever our notions are of deservingness. But I think another factor, which I didn't talk about, another historical factor is that in the US, we link health coverage to employment, or we've done that for at least almost 100 years. So in the 1930s and by the 1940s, employer-sponsored insurance was really the dominant source of coverage for most Americans. So we've tied healthcare coverage to work, which I think has reinforced these cultural expectations that insurance or health insurance is something that you earn. And the exception then is only those who are unable to work through no fault of their own. But if you look at other countries, like, they went down a different path, where most people, instead of getting health insurance from an employer, they were getting health insurance from the government. And I think that led in those many other countries this cultural idea that healthcare therefore is a right of citizenship rather than it's something that should be linked to working. I think that we just have these very different traditions in the US, welfare being linked to deservingness and healthcare coverage being linked to work. And so when Congress made that fateful decision in 2010 to cover the lowest income individuals through Medicaid rather than through the marketplaces, and with Medicaid historically being a program based on deservingness, it probably was only a matter of time, right, before the Medicaid expansion population would be told you need to earn this benefit by working.
Yeah. It also reminds me of something I meant to mention earlier as well, is that the whole issue of deserving or not deserving and healthcare is a right was actually, in my view, settled in the 1980s when the federal government, when Ronald Reagan was president, started the Emergency Medical Treatment and Active Labor Act, which said that every resident, it wasn't citizens, it was all residents, have the ability to get care in the emergency room. It wasn't talked as the person has the right to have it, but it was talked about the hospitals have to provide care in an emergency. So, we all have the right to care in the emergency room despite our ability to pay, but only when we're so sick that we're in the emergency room, right? Which is sort of the wrong place to try to improve health outcomes. You need to do that much farther upstream. So, but that has never been the political narrative about that. And so we struggle, I think, with this idea, or is Medicaid to actually improve the health outcomes of individuals, or is it there to protect the finances of healthcare providers? And there is no cash benefit that anybody on Medicaid gets. It is a mechanism to pay providers for services that those folks receive. And so it feels very different to me than a cash benefit, even if you say, SNAP is very important or some other form of welfare is important. Medicaid to me is health insurance, and none of us pay for our own health insurance, right? My employer pays the majority of my cost. We can argue about Medicare and whether or not I paid for it or not. I think I paid for my parents' Medicare, and my kids will pay for my Medicare. But those all of those programs, somebody else is paying for most of our health care. So the narrative that unfortunately we have sometimes doesn't match the facts as well as it should.
But it might
Just
be that,
two quick
oh,
thoughts.
good, sure, please.
Yeah, sorry.
No, go ahead.
Just, I don't know if we sort of settled the role of the government in terms of the provision of well-being for its citizens. I mean, to me, you look around the world at industrialized countries elsewhere, and they figured this out a long time ago. Maybe we just show US some grace because we are so young compared to them, but I mean, we are the only ones that don't do this. And then when I think about the, work requirement, I see sort of the opposite. I see some people that are limited in their ability to work by physical ailments that could be, relatively quickly resolved by a healthcare intervention. I mean, I've seen individuals, I've seen an electrician, for example, that broke his hand doing something non-work related, couldn't work because he had a broken hand and couldn't see an orthopedic surgeon because of lack of insurance. I see individuals with hernias that are considered elective operations, but if you don't have insurance, how can you? I mean, it's not an emergency. So they're sort of left on the sidelines, unable to work with things that, if they have an intervention, 6 months, they're back and working and productive again.
Yeah,
And it
and the
may
same
be,
with mental health and substance use disorders too. So many of uninsured actually have those conditions, and treated, stabilized, could in fact work. It's, I think Jessica said this earlier too. Which way does it go? It's the healthier people are able to work. It's not because you're working, you're healthier. So.
but it also could be the fact that, as Professor Mantell indicated, that our status quo, the position that we started with historically, was that you got your health care from your employer, and the people that aren't employed don't get health care, right? Except through the government. And so maybe that's where the connection with work is. Maybe people were saying, well, they should be working and they would have health care. And maybe that's how you connect them together.
Well, I mean, part of the big problem that they had with the Affordable Care Act when it was initially rolled out was the individual mandate. So it's an expensive product. So now
Yes.
the government's telling me I got to pay all this money for something I don't think I need. I'm working. I just don't want to put that much of my paycheck
Yeah,
towards that.
absolutely.
No, and that gets to the couple slides that I used where the take-up rate for people actually who are eligible for employer-sponsored insurance is actually declining, and something about only about a third of small employers even offer health insurance to their employees. So that thought that health insurance is actually connected to employment is actually deteriorating in the United States.
Let me ask one question from the audience and a closing question for the panel. So one of the audience members says that considering the immense cost of for-profit healthcare, limitations of the ACA subsidies, cuts to Medicaid, and the continued privatization of Medicare, what's the role of professionals in advocating for a broadly popular, comprehensive, universal healthcare system? So he's asking, how should people advocate for something better, stronger, etc., more comprehensive? Any thoughts? Now, we're not advocating. He's suggesting how we advise someone to advocate, right? I just want to clarify that we're not advocating. He's asking, how should he advocate?
Yeah.
Or how should others like him advocate?
I think the key thing to me to advocate, and one of the challenges that we have right now, is that the major players, the insurance companies, the hospitals, the doctors, the pharmaceutical manufacturers, the people that lobby on behalf of large employers, all point the fingers at other people, right? It's somebody else's problem. And one of the great things that happened in the ACA was that they were able to bring all of those players to the table and come out with something that everybody could live with. And so, I think what everybody should do is to advocate for how do we simplify the current system that makes it less administratively burdensome so that we can actually reduce costs and improve outcomes and cover everyone. It gets to that affordability issue. And I think the key thing to advocate for is you just can't pick your
for him to
favorite
advocate,
enemy.
for the audience member to advocate for you.
Yeah.
Okay. Any other thoughts?
I would
Well, they don't
say
listen to me.
They don't listen to
Go
you.
ahead.
They don't listen to me because I'm a greedy doctor. So the patient stories, I think, resonate more with our
Yes.
elected officials, and
Yeah, no,
telling
that's
them
true.
about the challenges they've encountered and how, something has to be done, something better. And, if you're taking something away from a policy standpoint, they could also discuss it. You made my life worse by doing this.
Right.
Yeah.
And
And I
probably
always-
should talk to the local congressman or woman or senator, or governor or whoever.
I always
was gonna
encourage
say
people to advocate for the healthcare triple aim. That is, that we should do, what can we do to improve outcomes, improve the experience for the patient, and reduce per capita costs simultaneously? Not one or two of those, but all three at the same time. And I think that that's actually quite doable.
I was going to say there's an active fight right now, so you could seek out, local community organizations and those who align with your views on that topic and take action. I think it is not the heart of your question, because I think the heart of the question is long term. How do we fight for the system that works for everybody? But I think there is a live healthcare issue now, and I in addition to patient stories, I completely agree with Dr. Reed. It's incredibly powerful and important to be framing, and even the anecdotes he's shared here today have really stuck with me. I think it's so hard to understand everything that's happening. So, the audience just sat on a very long CLE where we were talking about all these issues, but most people have no idea about the changes that are coming next year. Most people have and I think, a lot of the changes are going to be felt like they're coming from state policymakers versus federal policy. I think there's a fair amount of education in informing those you work with, so that people are really aware of what's going on that can be done in a neutral way that helps, I think, build the case long term for the kinds of changes that it sounds like you're interested in.
Mr. Mantell.
Oh, I'm not a political expert, so I'm not really sure. I will defer to what my co-panelists said.
Okay, great. Appreciate that. Last question. What do you see as the next major regulatory or policy frontier for the ACA and Medicaid? Payment reform, drug pricing, or something else?
Well, it looks to me like the next big thing is whether or not they're going to decouple the amount of premium tax credit people get from the cost of the second lowest silver plan. And that might actually be a really good thing. And if you're going to say that we're going to provide premium tax credits for people, it shouldn't be up to the insurance companies raising rates to determine how much that should be. So I think from a practical standpoint, the debate that we're going to have over the next 12 months or so. Not that there's not need to talk about drug prices and administrative simplification and a bunch of other things, but I'll start with that complicated topic about the amount of premium tax credits and how it's set.
So I'm always talking about payment reform because that's my thing. I've already mentioned it a few times, but value-based care, alternative payment models, it's actually one of the few areas where Democrats and Republicans generally agree. Both sides of the aisle appreciate that fee-for-service has been a problem for the healthcare system and would like to see more payment models that reward improved patient outcomes, care coordination, reducing costs. So, you might see some bipartisan maybe movement there with efforts to expand Value-based care, I think we're particularly seeing growing interest in that among state Medicaid programs. But I think there's also a desire to maybe strengthen the primary care system through enhanced payments.
Mhm.
As I mentioned, like value-based care really depends on a stronger primary care system. And so we're seeing more like trying to figure out through payment policy, maybe we can pay primary care doctors more. We pay or reward primary care doctors who integrate what they're doing with behavioral health care providers. We'll reward primary care providers who try to address the non-clinical risk factors like housing instability or food insecurity that contribute to poor health. So I think there'll be a growing interest there, including some state Medicaid programs, I think sorry, my light just went out, so I'm going to wave a little bit. Okay. A growing interest in giving Medicaid programs at the state level more flexibility to cover cost of interventions that address things like food insecurity and housing. So like a much more comprehensive view of what healthcare is. And then I think just reducing that administrative complexity for providers will also be a big focus.
Great. Any other takers?
Oh, I think
What's
we're in for
next? Good,
significant
yes.
double-digit coverage losses and the fallout from that with the midterm election coming and a lot of these, action and inaction to address. So
Mhm.
I would love to be in Professor Mantel's camp about all the ways that you could give states more flexibility and lift administrative burdens. But I think my view is I think we're on a different track, and it's from my perspective, speaking personally, it's going to get a lot worse before it gets a whole lot better.
Professor Reed, Dean, Dr. Reed.
Yeah, I agree with Professor Mantell that there is excitement, at least particularly amongst the primary care clinicians, about alternative payment models and more value-based care, more reimbursement for care that happens outside of the clinic, and leading to better health outcomes. But I'm very worried about the loss of access for individuals and going backwards in terms of insurance coverage and access.
Great. Well, this concludes our CLE. Thank you so much for participating. We really appreciate it.